Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Grand Rounds this week, where Dr. Can Ma, an anesthesiologist practicing in Toronto, Canada, presents on strategies to reduce post-op pain in craniotomy patients. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Thank you for your very kind introduction. I'm not sure if you can see, but I'm certainly blushing. I'll get started. First of all, thank you very much for the invitation. The topic I want to talk about today is post-craniotomy pain and the evidence-based approach for analgesic management. To start off, I do not have any conflict of interest to declare, unfortunately, and unlikely to have any conflict of interest to declare anytime soon. For today's discussion, we will talk a little bit about the anatomy, pathophysiology, as well as the risk factor of post-craniotomy pain, which remains to be one of the more under-recognized and under-treated phenomena. We'll explore the evidence-based approach to multimodal analgesia for craniotomy pain. And lastly, we'll finish off by talking a little bit about this, certainly a passion of mine, the idea of incorporating the role of regional anesthesia in managing post-craniotomy pain. So, if you look at the evidence, is that a lot of the, most of these are from sort of the mid 2000s to 2010s, where a lot of the evidence are coming out showing that the incidence of post-craniotomy pain is a lot higher than we thought. Some of the case series reported sort of in the low 30s or 40s, and some of the cohort studies report that up to 90% of patients undergoing craniotomy would experience moderate to severe pain post-operatively, with the worst pain happening within the first 48 hours, although in some instances that can extend up to a week afterward. The pain characteristics varies, and part of it could be the fact that it is certainly multifactorial, and we will talk about that. But more frequently, patients describe the pain as superficial as opposed to deep. They describe the pain at the surgical site as opposed to a diffuse pattern. And they also describe the pain more frequently as pulsating and pounding as opposed to a continuous pain pattern. And uncontrolled pain has its consequences beyond contributing to agitations and delirium. Poorly controlled postoperative pain in this context can result in severe tachycardia and hypertension, and that comes with undesirable physiological consequences, especially in somebody who recently had an intracranial procedure and there's some degree of cerebral dysautoregulation and the breaching of the blood-brain barrier. And so it is important for us to have this pain under better control. There are certain risk factors associated with post-craniotomy pain. We certainly see it more frequently in infratentorial craniotomies or suboccipital approach or subtemporal approach as compared to a frontal approach. This is a paper that was published I think it's by the Montreal group in the CJA back in 2007. And it was reported that the patients undergoing posterior fossa craniotomy have a higher incidence of severe pain and also require more higher opioid consumption post-operatively. And part of it may be related to the violation of the neck muscles during these approach. We also see that in, if the patients had the procedure done and not having the bone flap replaced, as in the case of a occipital craniotomy, that patient tends to have a little bit more pain afterward. Certain surgical techniques associated with more postoperative pain For example, the not using a fat graft to sandwich between the dura and the muscle, and the adherence of the dura to the muscle tends to cause a little bit more pain post-operatively. Longer surgeries, and as well as in many instances, the patients suffer from a post-operative complication, be it infection or CSF leak, that the patients tend to have a little bit more pain as well. What was interesting is that we also see when the patients have over drainage of CSF. Occasionally, we see that patients complain about this pulsating diffuse headache, and it was theorized that it's related to the over drainage of CSF and a compensatory cerebral vasodilation. And so they sort of present with this sort of almost like a migraine type pattern of headache. And we'll talk a little bit about specific intervention that can address that particular type of pain that we tend to see quite a bit following certain types of posterior fossa craniotomy. Certainly, there's a huge degree of patient influence as well. We do see that post-operative post-craniotomy pain is more prevalent among patients who are younger, female, patients with preoperative pain, as well as preoperative anxiety and depression. As I mentioned, it is multifactorial, but primarily based on the patterns that the patients report being superficial, being at a surgical site, as opposed to a diffuse pattern, as opposed to a deeper pattern. Certainly, a large component of this post-craniotomy pain is from somatic in origin. This is, as you know, sort of the majority of the scalp is innervated by branches of the trigeminal nerve. And then as well at the posterior part of the scalp, innervated by branches of the cervical plexus, as well as the ventral and dorsal rami of the C2 and C3. There's also a dural component to the pain. The majority of the anterior and the middle fossa, the dura is innervated by branches of the cranial nerve, the trigeminal nerve. Whereas in the posterior fossa, it's supplied by branches of the cranial nerve 9 and 10. The majority of the supertentorial dura is innervated by the tentorial nerve, which is a branch of the cranial nerve, the ophthalmic division of the cranial nerve 5. And so the dural pain, along with the somatic component of the scalp, that sort of contributes, that makes up the majority of the post-craniotomy pain for these patients. And so, the sort of the obvious solution to treating pain is just give more opioids. And certainly there is anecdotal observations from our practice that the injured brain seems to exhibit an increased susceptibility to the sedative effect of any sort of pharmacal interventions. Not uncommon that patients who presents in the operating room with impaired GCS, and they have an exaggerated effect to a small dose of opioid that otherwise would not have affected the 90% of your population. And certainly beyond the concerns of delayed emergence and impaired neurological exam post-operatively, we also worry that these exaggerated sedative effects may contribute to respiratory depression post-operatively, and that's just in the context of somebody with a impaired cerebral autoregulation and impaired CO2 reactivity. And so certainly we want to provide, with these patients, we certainly want to have a speedy emergence and the ability to perform a neurological exam in a timely manner. And so, maybe the solution is not giving more opioids. And so what other options are there? Actually, I do want to include a couple papers, actually. So beyond the anecdotal observation that our patients are more sensitive to the sedative effect, we do have clinical evidence to support that patients with a previous brain injury, be it from a supratentorial tumor or carotid disease or a recent stroke, that following receiving a small dose of sedative, be it benzodiazepine or narcotics, that they could either exacerbate an existing focal neurological deficit, or a patient who has no neurological deficits subsequently has appearance of a new deficit that correspond to the location of the lesion. And so this is something I'm always quite mindful of when I perform when I provide anesthetic for patients with intracranial disease, is to not to provide any sort of long-acting opioids or sedative that may confound the post-operative neurological exam. So what options are there? So I will go through this. This is a paper that was published in EJA, I think it was probably the fall of last year. It's part of the a guideline from the European Society of Regional Anesthesia and Pain Therapy. They performed a systematic review that included RCTs and meta-analysis between January 2010 to June 2023. And essentially, they looked at pharmacological interventions, as well as non-pharmacological interventions for management of craniotomy pain. And so these are the recommendations, and I'll go through a couple of them in detail. So essentially, they recommended the use of acetaminophen and NSAIDs, both preoperatively as well as postoperatively. They recommend the use of intraoperative intraoperative dexmedetomidine for management of craniotomy pain, with a caution against the potential side effects of cardiovascular profile, as well as potential for postoperative sedation. They recommend that patients should receive either incision site infiltration and or scalp block as a routine management of patients undergoing craniotomy, and that opioids should be reserved as a rescue analgesia due to concerns of the undesirable side effects of opioids. And so I will talk a little bit, a couple of these analgesic options that they recommended and saw the evidence behind it. Interestingly, even though the acetaminophen was recommended as a routine analgesic option for these patients, the evidence supporting it is not basically shows that it really has very minimal effect on perioperative pain in this patient population. All these studies uses intravenous acetaminophen intraoperatively and then continue postoperatively for either 6 to 24 hours, and really shows that there makes very, if at all, very small effect on reducing postoperative pain scores. But just given that there's such a low side effect, such a favorable side effect profile, it's recommended as sort of what they call a basic analgesic plan that should be incorporated to all patients undergoing craniotomy. The use of NSAIDs actually have a much better evidence supporting this. This is a lot of studies are done in Europe, so they do have intravenous diclofenac. Versus in North America, I believe the only intravenous NSAIDs that we have is a ketorolac. And so a lot of the patients undergoing, and all these patients are undergoing supratentorial craniotomy. The use of a single dose NSAIDs even has a pretty impressive effect of reducing postoperative pain scores as well as opioid use up to 24 hours postoperatively. Obviously, there is a concern regarding the use of NSAIDs and the effect that it has on platelet aggregation. And I've heard from the surgical team who prefers to not give NSAIDs to their patients, and not just neurosurgeons, just surgical team in general who prefer not giving NSAIDs for patients due to concerns of bleeding, and that's sort of been ingrained in in our practice. What's interesting is that among all these RCT looking at the use of NSAIDs in craniotomy patient, there's been no difference in the incidence of postoperative bleeding. There's an interesting paper that was published in Journal of Neurosurgical Anesthesiology back in 2022, where it was quoted here, where the patients got diclofenac at closure and then every 12 hours for 2 days. And so they're not only looking at postoperative pain and opioid use, but they also measured platelet function as well as clotting time at 24 and 48 hours. And essentially between diclofenac 1.5 milligram per kilo essentially for 2 days comparing to placebo. There has been no difference in platelet and clot function, and obviously, and certainly there's been no difference in the instance of postoperative hematoma in this patient population. So perhaps the use of NSAIDs are a lot safer than we were led to think initially. But I do suspect that we do need a slow change of narrative, a change of our practice pattern to incorporate NSAIDs in our routine practice. As I mentioned earlier, the guideline also recommend the routine use of dexmedetomidine perioperatively for controlling for reducing postoperative craniotomy pain. The evidence supporting is actually quite strong. Although it is important to note that in one study they were able to see that the patients had a lower Ramsey sedation score in PACU up to 6 hours postoperatively. One study compared the use of dexmedetomidine versus remifentanil and showed that there is a prolonged emergence associated the use of dexmedetomidine. Although I do have to caution the way that they did this, how they defined prolonged emergence was the time of eye opening from the time of switching off the drug to time of eye opening. And so, in that studies, when they switch off the remifentanil, patient woke up in 8 minutes. After they switch off the dexmedetomidine, the time to eye opening was, I think, 38 minutes. So again, it's not. It's something that we, at least when I use dexmedetomidine for whatever reasons in both surgical and non-surgical procedures, I tend to turn my dexmedetomidine off a little bit earlier than just surgery's done and I turn it off. I tend to turn it off probably 15 to 20 minutes beforehand. So that hasn't been much of an issue, at least in my clinical practice. There's also reported of decreased postoperative shivering as well, post-op nausea, vomiting with the use of dexmedetomidine, likely related to the fact that we're giving less opioids to these patients in the recovery room. They also this guideline also went through a couple of the interventions that are not supported by the evidence, and a couple of which I'm just going to go over. I'd like to focus on is the use of gabapentinoid, magnesium, lidocaine, as well as somatriptan. I do recall during my time of my residency training, it is not uncommon that we will give patients gabapentinoid as part of the multimodal analgesic protocol for all patients. Certainly over the last few years, more evidence has come out that gabapentinoid might not do have certain unfavorable side effect profile, mostly related to postoperative sedation and may contribute to postoperative delirium. And so over the last few years, certainly even on our acute pain service, we've been prescribing less gabapentinoid to our patients. And in particular, this becomes an issue for patients undergoing intracranial procedures who you already worry about postoperative sedation, and that the use of gabapentinoid might actually exacerbate this. This was published in JAMA Internal Medicine back in 2022. Large retrospective cohort with one-to-one propensity matching of over 200,000 patients with who are over 65 who were not on gabapentinoid but was started gabapentin perioperatively. And based on this large cohort of propensity matching, we do see that perioperative initiation of gabapentinoid has been associated with increased incidence of delirium, increased incidence of pneumonia, as well as increased incidence of new antipsychotic use in hospital. And so as a result of this, even though the evidence does support that gabapentinoid does help with postoperative craniotomy pain, that it is not recommended by this guideline to be used as a routine analgesic option. There was actually a small study that was back in 2019 looking at the use of magnesium and lidocaine for post-craniotomy pain. And this is the only study that the guideline was able to find. And I did a cursory search, and that's the only study I was able to locate. But essentially, there's a very small single center study. 45 patients, three groups. You either get the placebo or a lidocaine or a pretty hefty dose of magnesium. And essentially beyond the pain scores, there's certainly a statistically significant difference observed at multiple time point. However, remember that this is the FAST score is actually out of 100, and really, if you look at the different time point beyond the out emergence as well as 1 hour post-op, the difference in pain scores between each of these intervention and the placebo I would consider that a statistically significant but clinically irrelevant, a clinically insignificant difference in pain scores. Will be less than 10 between each group. There's also a concern about the use of magnesium intraoperatively, especially with this dose. We do see that with a high dose magnesium, you can cause affect the end plate potential. And so we with this dose, you actually see a train of four can drift down to two twitches. And so if the patients are undergoing intracranial procedure with intraoperative neuromonitoring, this dose will be prohibitive with motor evoked potential. So something to think about. And certainly based on the lack of robust clinical evidence, this is not something that I incorporate into my practice routinely. Interestingly, there's this is actually a paper published in BJA back in, I think, 7 years ago. The use of somatriptan for patients undergoing microvascular decompression. And this goes back to this, what I talked about earlier, where a lot of times in these procedures, that when there's an over drainage of CSF, there is a theory that with a drop in your CSF volume, you compensate by vasodilating your cerebral vessels, and that resulted in this sort of migraine type pattern. And there's a small study, single center study in 50 patients, and basically the use of a single dose sumatriptan at the recovery room improve quality of recovery as well as reduce post-operative pain in this patient population. There's a retrospective cohort from a single center that was published a couple years, 2-3 years ago, also looking at, actually, it's for all craniotomy surgery. Basically, the use of somatriptan as reduces post-operative pain as well as opioid use. But just because there is only a single randomized controlled trial out there, and due to limited evidence, this is not one of the recommended intervention by this guideline, although I do use this quite frequently in my practice. When I try absolutely everything, I do try giving patients a single dose of somatriptan. I do want to spend a little bit of time. So at the end of the guideline part of it, guideline also recommended the use of scalp block as part of our routine analgesic protocol. And I do want to spend a little bit of time talking about the incorporation of regional anesthesia in our practice. This is something that I do end up doing quite frequently from a day-to-day practice. Obviously, I taught my fellow this, and she actually went on to make a really excellent video on scalp block. So I figure I should, instead of me talking about it, I figure I'll let her talk about it. So let me know if the audio doesn't work. Just flag me down. So I'm just going to play this 3-4 minute clip.
Hello, I'm Dr. Aida Velasquez, Neuroanesthesiology Fellow at the University of Toronto. In this video, I'll guide you through the scalp block technique, a simple yet effective procedure essential in the management of neurosurgical patients undergoing craniotomy. I'll also share some useful tips based on our research of the literature as well as my personal experience. For the setup, we're going to need 2 10cc syringes, 25 gauge needles, your choice of local anesthetics and concentration, sterile gloves, prep stick with antiseptic solution, and gauze. Let's get into the scalp block technique. Same as with any other block, begin with a brief timeout and prep the skin with antiseptic solution. Go from the forehead to the laterals of the head, as well anteriorly and posteriorly to the ear. Do the same with the other side. This technique involves 7 nerves on each side. I'll be using a total of 20 mL of local anesthetic. Although higher volumes has been described, it's always a good idea to calculate the toxic dose, especially if local skin infiltration is planned. For the anterior and frontal part of the scalp block, start with the patient's head in a neutral position. First, locate the supraorbital notch 2.5 centimeters lateral to the midline. Use your non-injecting hand to palpate the superior border of the orbital rim. Keep your finger in place to control the block spread and to protect the eye. Insert a 25 gauge needle perpendicular to the bone, 1 centimeter above the notch. Aspirate and inject 1 ml of local anesthetic to block the supraorbital nerve. At the same injection site, flatten the needle and advance 1 centimeter towards the midline to reach the supratrochlear nerve. Again, aspirate and inject 1 ml of local anesthetic. As a recommendation, after each injection, gently massage the area for even distribution. Now, carefully turn the patient's head to the side to work on the lateral and temporal part of the scalp block. Locate the zygomaticotemporal nerve in the area between the lateral border of the orbital rim and the upper part of the ear. As this nerve branches multiple times as it emerges through the temporalis fascia, both deep and subcutaneous injections are required. To start, palpate the orbital rim and create an imaginary line to the ear. Half along this line, or 1.5 centimeters behind the orbital rim, advance the needle at 90 degrees till bone is contact. Aspirate and begin with a deep injection of 1 ml of local anesthetic, followed by a superficial injection of 1 ml. Massage the area for better coverage. Move towards the ear and identify the tragus. The auriculotemporal nerve is located 1 centimeter anterior to the tragus, and it's posterior to the superficial temporal artery, above the level of the temporomandibular joint. Palpate the pulse and advance the needle posteriorly and superficially to reduce the risk of unintended facial nerve palsy, as motor branches are distributed deeper. After aspiration, inject 1 ml of local anesthetic. Gently massage the area. Locate the greater auricular nerve situated 1.5 centimeters behind the ear at the level of the tragus. Insert the needle perpendicular to the skin till bony contact is made. Aspirate and inject 1 ml of local anesthetic. Gently massage the area. Now, let's move to the posterior part of the scalp. Palpate the mastoid process and follow the inferior nuchal line to the occipital protuberance. Part the hair for better exposure and prep the skin with antiseptic solution. Divide the nuchal line into thirds. The lesser occipital nerve is found at the junction of the first and the second third. Here, advance the needle perpendicular to the skin. Aspirate and inject 2 ml of local anesthetic. Gently massage the area. Finally, the greater occipital nerve. Locate the greater occipital nerve between the second and the third thirds. An important landmark for this block is the occipital artery, as both may be found close in proximity to one another. If you can palpate the pulse of the occipital artery, insert the needle 1 centimeter medial to it. Aspirate and inject 2 ml of local anesthetic. Massage the area. As an additional technique that complements the scalp block, Cedar.
Apologies. Let's move on to our next slide. Perfect. Yeah, so that was well, it's good to have a little break from hearing my voice. So that was actually my fellow who did an excellent job. That was without any kind of coaching. So that was she really made me proud there. So, what's the evidence of using scalp block in craniotomy patients? So those this article was published in Neurosurgery, I think it was December of last year, so or November of last year. This is from the Hamilton group, neurosurgeons from the Hamilton group. Essentially, they looked at, it was a meta-analysis and systematic review of 22 RCTs in patients undergoing craniotomy, most of which are supratentorial craniotomies. And they compare scalp block versus either a sham block or a scalp infiltration or no injections at all. And what they reported was that the use of scalp block was associated with reduced pain scores up to 48 hours with moderate to high certainty. There were 2 studies that looked at pain scores beyond 48 hours, and both of which show that there was reduced pain scores up to 72 hours following the block. It also reduces post-operative opioid consumption up to 48 hours, reduce post-op nausea, vomiting, but though it does not add significant amount of time to the procedure. It has no difference in surgical durations and no difference in hospital length of stay. As my fellow sort of mentioned, there are different local anesthetic cocktail that everyone sort of swear by. This is a network meta-analysis that was published last year in Journal of Neurosurgical Anesthesiology. It seems like the use of ropivacaine might be slightly better, although I would say that likely as long as you're using some kind of a long-acting local anesthetic cocktail, that the patient should have reasonable pain control, reasonable analgesic benefit at 24 hours. Interestingly, when certain they look at, which there's always this question about should we do the block before incision or after incision. Based on this network meta-analysis, doesn't seem to matter for post-operative pain at 24 hours. Personally, I try to do it before the surgery, before the surgical incision, so that I can avoid giving intraoperative opioids. And also following the procedures, depending on the location of the scalp incisions, makes it a little bit worry about injecting close to the surgical sites, which can lead to undesirable complications, which we'll talk about next. Top of complications. So in my practice, I tend to do it on almost everybody for both a sleep and awake craniotomy. But there are certain complications that we should address, one of which is the facial nerve palsy. This was a study published 2 years ago. It was the cadaver studies. Essentially, they were this group of clinicians. They were injecting methylene blue to the auriculotemporal to simulate doing a auriculotemporal nerve block and a zygomatic temporal nerve block. And if not a lot, just 2 cc of methylene blue and at the auriculotemporal location and 1 cc at the zygomatic temporal location. And what they find is that among the 8 specimens, they stained 5 of the temporal branch of 5 of them, causing would have caused a partial facial nerve palsy. If you knock off the temporal branch, you won't be able to raise your eyebrow. So essentially, patient has a bit of apoptosis. If you knock off the zygomatic branch, patient will be unable to close the eyelid because it innervates the lower part of the eye muscle, so they won't be able to close. Interestingly, despite such a high incidence of staining of the facial nerve, I actually have not had a single facial nerve palsy until yesterday. And so I guess it does happen. And I'm certain that I'll run into more of these complications in my practice in the next 20, 30 years. The other complications that I do want to talk about is the incidence of block failure. And it has to do with the significant anatomical variations of which these nerve runs. Very not uncommonly doing awake craniotomy, despite a very good scalp block, when the surgeons are pulling off that temporalis muscle, patients very often still feel a lot of discomfort and pain and often require local anesthetic infiltration. And that has to do with the way that the zygomatic temporal nerve runs. This is a cadaver studies, pretty old, like 12, 15 years ago. But essentially, there's 25 cadavers. They dissected each side of the face, so you get 50 specimen. Essentially, the zygomatic temporal nerve, half of it runs through the muscle, half of it runs outside the muscle. Up to a third of them have very early branching before it pierces through the temporalis fascia. And in small percentage of patients of these cadavers, instead of having one zygomatic temporal foramen, they actually have 2. And so, depending on where you inject and how deep you're injecting, you might actually end up missing some of the early branching of the zygomatic temporal branch, which I suspect may contribute, maybe the reason why some of these patients, despite a full scalp block, still feels a lot of pain when the surgeon flip open the temporalis muscle. There are certain different ways of doing zygomatic temporal nerve block. This is actually taken from a textbook written by my old PD from Northwestern, and there's no audio, but essentially how I was trained was I take a long 25 gauge and I hit bone, I flatten, and I go all the way near the lateral orbital rim, and I inject 3 cc. And as I pull back, I inject 2 more cc as I pull back. And so supposedly, based on the anatomical considerations, that if I inject close to the lateral orbital rim, that I'm more likely to catch any sort of early branching of the zygomatic temporal branch. And so maybe, at least that's how I was trained, but there's no evidence to support that one technique is better than the other. And at least in my practice, not uncommon that the surgeons have to help infiltrate the temporalis muscle, despite the modification of my technique. It's also important to note the anatomical variation of the occipital nerve. This also is a cadaver study from the same group. And essentially what they find is that even though classically we're taught to, look for the occipital artery, medial to it, inject, that's where the greater occipital nerve is. 50% of the time, the nerve actually the artery actually kind of wraps around the greater occipital nerve. And so depending on where you feel the pulse, the nerve might actually run lateral to the pulse opposed to the medial. And so for wake procedures, for a sleep procedure, I tend not to pay too much attention. But certainly for a wake procedure, if I can find the occipital artery, I tend to block both medial and lateral to the pulse, just in case. And I do want to make sure I can catch the great occipital nerve that way. Other complications that have been described, when we're doing the supraorbital nerve block, there's often a supraorbital artery that can run right beside it from the same foramen. And so if you nick the artery, you can cause a hematoma and resulting in mechanical apoptosis. Because it is a trigeminal nerve, the performance of scalp block can cause trigeminal cardiac reflex, especially if the patient is just mildly sedated. Keeping in mind that the scalp is highly, highly vascular, and so certainly be mindful of the calculation of the toxic doses, and also ensuring negative aspiration before injection. Because of the high vascularity of the scalp, I tend not to put epinephrine with my local anesthetic because I don't really like seeing the hemodynamic effects associated with the epinephrine, a rapid epinephrine absorption of the scalp. It has also been described that during scalp block, you can actually inject directly into the brain, especially if the patient has a is undergoing cranioplasty, so there's no bone flap. Or there's a redo craniotomy, and you can actually slip the needle between the bone flap, bone cracks, and actually inject into the brain, and essentially giving a total brain anesthesia. Not a contraindication, but certainly makes me have a high degree of caution is if the patient doesn't have a bone flap or if there's a redo craniotomy. I certainly look through the CT scan and make sure that that wherever I normally would inject that there is bone overlying it. Because of the incidence of cranial nerve, facial nerve palsy, I tend not to do it if there is cranial nerve monitoring for that psi. And if there's an existing VP shunt, very often they run behind the ear where the shunt is. And so when I perform the posterior auricular nerve block behind for the posterior auricular nerve block or less occipital nerve block, I tend to be a little bit more cautious as well, or I just avoid it altogether. I've heard surgeons who mention, well, we do neural navigation. Can you do it after neural navigation? Or, they will say that, oh, when you inject onto the scalp, it creates all these bumps on the face. It throws off our neural navigation. There's no clinical evidence to support that. There's a small studies where they were using, I think they were using Medtronic in this study, where they're doing neural nav pre-block and post-block. And so really it has no difference in their accuracy registration following the block. And so scalp block does not interfere with neural navigation. Someone asked me recently about the use of adjuncts in scalp block. Really, there's not a lot of good evidence to support it. There's a single study that looked at the use of perineural dexamethasone with the local versus just straight local. And really, there has been no difference in perioperative analgesia use, although because in those population, it was a supratentorial craniotomy for tumors. So everybody got intravenous dex or even preoperative dexamethasone. And so that becomes a confounder, and perhaps the dexamethasone itself, given intravenously, it's equivalent to giving it perineurally. And maybe that's the reason why we didn't see a difference. There's a couple small studies that looked at the mixing perineural dexmedetomidine 1 mics per kilo. And we do see that there is a decrease in heart rate and hemodynamic parameter during incision and dura opening. And there is a prolonged analgesia in the perineural dexmedetomidine group. It is important to note that because it is the scalp is very vascular, I always wonder how much of it is just the fact that your dexmedetomidine is being absorbed through the scalp, and there is a systemic effect of the dexmedetomidine as opposed to a effect. And there's been no study that that looks at that. And so, personally, I don't do it. And because all my patient ends up getting dexamethasone anyway, and I feel like the patient would benefit from dexmedetomidine, I just run an infusion as opposed to mix it into my local. There's some practitioners who advocate the use of ultrasound-guided scalp block. I use it very, very sparingly, only when I really think I need to do this block and there's really difficult or absent landmarks, or if I suspect any sort of bony defects. Honestly, most of the time, if it's a sleep craniotomy and I find it really difficult, or I'm really worried about missing bone flap, I just don't do it. But it is this technique has been described, and so you can just take a very ultra high frequency probe. It can actually roll across the orbital rim. And you can actually see that there is a supraorbital foramen, and occasionally you can actually see that some patients actually have 2 supraorbital foramen, and in some cases you can actually see that there's an artery that comes out of it, that runs parallel to the nerve. And so there's a theoretical benefits of using an ultrasound guided technique. They can avoid any undesirable vascular injury resulting in mechanical apoptosis. So this is just a very quick 6-second video. This is actually my scalp. As you can see that I'm just sort of rolling the ultrasound, and you can see the supraorbital notch. At this level, you can't really see the nerve. All you can do is visualize the landmark. You can also see, with orbital-temporal, you can really identify the nerve, but you can certainly see the superficial temporal artery that is pulsating. Or you can just do a landmark technique and just make sure that you go posterior to the pulse. So I will say the clinical utility of this is not great, at least not in my practice. Zygomatic temporal nerve block. Again, you can't really see the nerve, but there is a deep temporal artery that runs underneath, right beside the temporal bone. So when you inject, you can, if you see it under ultrasound, you can avoid hitting that. And you can also ensure that your needle pierces through the temporalis fascia, and making sure that you're injecting below the fascia so that you can catch the early branching. You can see the greater auricular nerve. This is not something that I do routinely, but I'm just including this for completion's sake. And you can also see the lesser occipital nerve. If you put your ultrasound sort of right above the sternocleidomastoid, and this little thing here is the lesser occipital nerve. Again, not something that I would do routinely. The occasional time when I couldn't feel the pulse, I do use the ultrasound to look for the occipital artery. This is my head, and so I do have hair in my back, and so despite having hair on my scalp, I'm still able to see the the occipital artery, and so medially, this is where the great occipital nerve is supposed to run. And as I said, I tend to sort of do an injection medial and one injection lateral just to make sure that I do catch it. There are other the people also look at the use of play with the idea of doing a sphenopalatine ganglion block for craniotomy pain. So far hasn't really panned out. There is two small studies looking at the use of superficial cervical plexus block for infratentonal craniotomy, and that seems to be promising. But there hasn't been a lot of these are the only two studies I find. One of which, this one's published in CJA. I think this is from the Montreal group. It was published in CJA. Basically, the use of superficial cervical plexus block, it's comparable to using morphine for postoperative pain. And in this case, in this small studies of, I think, 40 patients, cervical plexus block reduced postoperative pain and opioid use for suboccipital craniotomy. There are other people who are who play with the other. I remember one of my colleagues was toying with the idea of using blocking the cervical spine interfascial plane blocks for Chiari malformation. And again, they published a small case report on it, but again, none of this has been supported by clinical trials. But certainly this is something that we, as neuroanesthetists, we do keep this in. It's something that we're a lot of time we like to explore different options of doing regional anesthesia, different options of regional anesthesia, in hopes of avoiding the systemic side effects of any other pharmacal interventions, which may contribute to post-op sedations. So as a concluding slide, to remind us that post-craniotomy pain is a under-recognized and under-treated phenomenon. It is multifactorial, even though the large part of it is somatic. The evidence support the routine use of NSAIDs and acetaminophen, and as well as scalp block or surgical site infiltration, and a select use of dexmedetomidine infusion for management of these patients. And that I do think that given really the learning curve, it's quite I would say it's actually quite easy to pick up this technique, and very frequently I would show a trainee or a colleague once with a scalp block, and they're relatively independent after seeing it once or doing it once. And so I am a big advocate of incorporating regional anesthesia in our neuroanesthesia practice. And so that concludes our presentation. Thank you very much for your time. And I look forward to having a fruitful discussion with everyone here.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.